Great pleasure to welcome Natalie Elphick to the stage. Natalie is the Falls Coordinator in CNC from Illawarra Shoalhaven Local Health District, and she's talking about the district overview of her falls prevention. Welcome, Natalie.
Thank you very much for having me. When I first came into this role 2 years ago this month, it was a bit of a slap in the face. Falls fatigue was real. ISLHD had a big problem with falls, but also with how tired everyone was. So we wanted to look at some new innovative ways that we could bring support to a workforce that we know already works extremely hard to keep our patients safe. I've always said to my managers, and they've struggled with it, falls prevention and improvement in the falls space is not a race, it's a marathon. And whilst a quick win is good, we're always looking for something that's sustainable, that we're actually going to be able to see the benefits of our hard work long term. So I'm going to show you a couple of the wonderful projects that we've been working on in ISLHD, because things work better as a bundle. But before we go there, I'd just like to show you where we've actually made some improvement in terms of our falls reduction and in harm. So as you can see up on the board there, we've made some pretty big gains. So when we are comparing our harm score 2 data from 2024 to 2025, we've actually had a 56% reduction in harm score 2. It's quite astronomical, and it comes down to a seriously large amount of hard work from everyone across our district. And also we only had, it's never only, one is too many, but one harm score 1 for 2025. You can also see the large number of harm score 4 incidents, where 69% of our total falls are a harm score 4, so that shows an incredibly healthy reporting culture. Like most other districts, our problem area is the bedside, with more than half of our falls happening at that location, and we still have quite a significant issue with unwitnessed falls. So a lot of our targeted strategies have been focused on those trends that we've been identifying. What is truly promising is that when we have been comparing our data for the first quarter this year from the first quarter last year with our incidents resulting in harm, we are 33% decreased again. So we know we are definitely moving in the right direction. This graph sort of sums it up beautifully, and you can see, I hope you can see, where we've actually implemented a couple of the things I'm going to be discussing today, which was the Clinical Leaders Program and our Falls Response Team, which is a senior MDT huddle. So when we were reviewing the data from 2024, our 2 areas of highest falls were our 2 acute geriatric units in Illawarra Shoalhaven. The thing that was truly worrying is that 45 to 55% of our total falls were made up of patients that fell 3 or more times. We knew this was a problem area that we needed to do something about. We also knew that the nurses in these areas are incredibly skilled and experienced and have a wonderful knowledge base in terms of keeping our patients safe with falls prevention. So we wanted to look at a supportive framework for them. And the wonderful Raj from Southwestern Sydney had spoken to me about a falls response team model that they had at Southwestern Sydney. So we looked at it and decided we were going to do this as a research project in ISLHD. As you can see on the screen there, that is actually a picture of the first falls response team huddle that took place. Had a wonderful turnout. It is included in the group. You'll have your nurse unit manager and the CNE, plus a falls prevention clinical leader. You also have to have a member of the executive team. So whether that be your Donum or an ops manager. You also have your relevant CNC, so me, and aged care for most of our falls response team activations that occurred. We have medical representation, allied health, pharmacy, and of course the patient and carer. So this was the flow sheet that was provided to the sites. There was questions around why did we not do this on the second fall. That's simply because there is an expectation that if a patient has fallen twice, that we are doing a far bigger deep dive at a ward level around what has happened for that patient and what safety mechanisms we need to put in place. By the third fall, we know that area needs help. They need support from organisational level to come in and actually offer the support that's needed. What that support looks like could be a multitude of things. We should be looking at things like staffing, skill mix, patient cohort. Is there a significant number of behavioural patients that's becoming extremely difficult to manage? Are you short-staffed? Do you have a lack of equipment or broken equipment? Are you having issues with escalation for medical review, consults, testing, etc.? And also having that conversation with the family around what works at home, what do you think is happening for your loved one in hospital. We did find, however, that including the care, all of our patients had severe cognitive impairment that the falls response team was activated. So none of them were able to participate in the huddle. However, we did find that it was quite intimidating for the carers because there's a lot of people coming in and most of them were face-to-face. So we picked a couple of members of the team that would then go back and update the family on what had been done and ask for their input. This was all documented also and added into the medical record. In terms of staff feedback, it was incredibly positive. Staff felt very supported. There was an initial fear that this would be a blame culture. That is not what this is about. We are not here to blame. People do a really good job and they try very hard. This is about shared responsibility, shared ownership, and taking the load. So everybody is actually participating, and that the clinical staff on the floor can see that senior level staff care, and they are trying to do their best to help them also. It was also really good to see the MDT approach because, like Lucy and team said in their presentation, most of our safety huddles are nursing-led. I will also point out that our falls response team is an additional thing. So all post-fall safety huddles would still have occurred as per normal. So one of the wards actually had just over 50% decrease in total falls and a 60% decrease in patients experiencing a repeat fall. What we did know, though, that we needed to look at a larger cohort. We needed to gather more data. So the two wards that trialled it last year have taken it on as business as usual. They have a firm belief in the process. But we have identified our 4 biggest repeat falling areas, and we have started the second falls response team trial on the 1st of April. And fingers crossed, we've only had 1 activation so far. So that's actually really promising that things are going well for falls. The other thing that we have been working on since the back end of 2024 is our Falls Prevention and Safe Mobilisation Clinical Leaders Program. This is a passion piece for me, something I strongly believe in. We often ask a lot of our clinicians, but what do we give back? So we knew we needed to do something in the space of falls, and we needed leaders all over ISLHD. What we also needed was to be offering support and the chance at professional development. So this was not a case of pick someone from your ward and they're nominated. This was an expression of interest. People actually had to demonstrate that this was something they were interested in and they actually wanted to commit, and they needed written approval from their manager as well. So the picture on the screen there is actually from our second training day that took place at the end of last year. There are various roles and responsibilities of the group. We have a community of practice, so we have a monthly meeting. They are also all members of their site falls working parties. They are expected to provide education and training and develop quality initiatives. And after my presentation, you're going to hear one of the best things you'll probably ever hear. Collaborate with the CGU and myself, of course. They also have been given falls-specific IMS access, so they can manage their IMS investigations for their units. And they also participate in harm score 2 reviews. And they should be feeding all of that back to their wards. Just on the screen now, because I'm very proud of them, just show you some of the faces of our wonderful falls prevention clinical leaders. They come from all different areas. So we've got ED, geriatrics, day only, medical wards, surgical wards. We've got acute, subacute, and they all have a real passion for why they're there and a commitment. We shared this district-wide on our notice board so everyone could get to know and meet our clinical leaders as well. We also do shared learning opportunities. This was a wonderful day where we got together as a group and did the In My Shoes program at Bly. If anybody's heard of that, it's an amazing initiative that was set up by Alira Bowden, our research manager for the district, and it's really about making you as vulnerable as you could possibly be. So you can't see properly, you can't hear properly, they put weights on your arms, so it's difficult to even lift a cup of tea, and not only was it amazing to do as a team, but it's also amazing because it puts into perspective why we are doing what we are doing and why we are so committed. We now have 45 members, so 40 nursing and 5 allied health, and in that we have now 4 CNSs and 1 CNS, a further CNS application that's been submitted. The team are actively engaging in quality projects. They are facilitating and delivering ISLHD-wide nursing and midwifery falls orientation. We have a very active MS Teams channel. One of our wonderful clinical leaders had developed that far that she was actually able to co-facilitate our training day last year. They were imperative in our EFRAMP planning and launch, which has gone extremely well also. And just recently, 3 of our falls clinical leaders have come on to co-lead the group. So now we're trying to make it more self-sustaining, so they will lead the monthly meetings as well. I guess the point here is that peer-led change works, and when we invest in our wonderful clinicians and we show them support and we commit to their professional development, it works. Those areas that have coverage of a clinical leader have actually a higher number of decrease in harm score 2 incidents, up to 58%. We're incredibly proud of all their hard work, and they are very, very well respected throughout ISLHD. Thank you.
Thank you, Natalie. We have time for one quick question for Natalie. There's no questions online. Nothing in the room? Thank you. Great. Well, now we have yes, sorry, there is one question just down the front. Thanks.
Hi, that's amazing initiative and project. I just want to ask, how supportive is your executive team and your staffing with regards to additional help when you identify that there's a lot of confused patients in one area? Considering that we know that the first special is always, I don't know if it's in your district, but in our district, the first special is within your number and you need to cohort everyone else. And how supportive are they?
We are lucky that we actually have a very supportive executive, particularly of the wards that took part in the falls response team. Having said that, the patients are usually where they need to be because that's a safer environment, it's a lockable ward, the staff have far more experience in managing behaviours, so what we do find is that the patients are actually safer there. So they are good. Look, we're like any other district, there's no staff. It's very hard to get a nurse special. But what we can do is try to find additional support. We can look at additional equipment. We can look at how we're splitting up the ward with acuity. And I do know that they do organise additional rounding with security, additional rounding with the executive themselves. They'll get the after hours ICU liaisons to come and spend time on the ward. So there is support that's definitely implemented.
Great, thank you.